Now we are recording, and I will show my screen. Okay, great. So, hello everybody. Thank you for joining today. I'm working from home because of the current situation, and we will be presenting a webinar. So, Marc Engelen from the University Medical Center in Amsterdam in the Netherlands will be presenting webinar on the X-linked adrenoleukodystrophies. And I would like first to present myself for those of you that haven't still attended one of our webinars. I'm Sanja Hermans, and I work for the University Hospital Tübingen at the Institute for Medical Genetics, and I'm the training manager of the European Reference Network for Rare Neurological Diseases. This webinar is part of our joint webinar series that we are organizing together with the European Reference Network for Rare Neuromuscular Diseases and together with the European Academy of Neurology. So these webinars are all on rare neurological, neuromuscular, and movement disorders. And we are always having approximately 35 minutes of presentation. And at the end, you have the possibility to ask the speaker questions. So please write your questions in the Q&A section, which you can find in the lower toolbar. And for all general questions, you can please write me in the chat box. So the target audience of our webinars are neurologists, residents, pediatric neurologists, geneticists, and other paramedical personnel, which is involved in patient care. And as I said at the beginning, we are recording these webinars, so we will put the recorded version at our website. The link you can see here, and along with the slides of the presentation. And also you can check another link which is here, so another part of our website which is on disease knowledge. We have disease knowledge documents in each of our 6 disease groups that we are covering. At the end of this webinar, your browser will open automatically a satisfaction survey. So it will be great if you can fill it out. It should take only 2 or 3 minutes, but it gives us very valuable and precious feedback on how we can improve our webinars. And there you can also enter some suggestions for future topics. So please do not hesitate to participate in that survey. And I just would like to give a little overview of what are the European reference networks, because we have attendees from all over the world, and maybe not everybody is familiar with the European reference networks. So those are groups of expert centers in Europe, and they have specific knowledge and expertise in specific diseases. So, for example, our network is covering the rare neurological diseases, and in foremost the 6 ones that you can see here on my slide. So, ataxia and HSP, leukodystrophies, dystonias, chorea and Huntington, FTD, and atypical Parkinsonism. And you can see that in the countries which are dark blue, we have full member hospitals, and in the countries that are light blue, we have affiliated partners. And there are 24, in total 24 European reference networks, depending on the type of diseases they are covering. Okay, so now we come to our today's speaker. Marc Engelen from the University of Amsterdam. He's a neurologist and pediatric neurologist. He's also affiliated to the Amsterdam Leukodystrophy Center. He follows a large cohort of patients with X-linked adrenoleukodystrophy, so he has a special expertise in this disease, which is why we have invited him today. And he is the local PI for the Minorix Advance study. So Marc, thank you very much for accepting the invitation and for giving now this talk. And I will now stop my screen sharing and you can start with yours.
Okay, thank you, Sanja. I will try to start up the presentation now. Can you see the screen?
Yes.
Excellent, excellent. Okay, well, thank you very much for the invitation to present on X-linked adrenoleukodystrophy. We're lucky it's a webinar because I think every other presentation right now would have been cancelled. But what I'd like to do in the next, I think about 30 minutes, is to give you an overview of the biochemistry of ALD, of all the clinical features, on some tips and tricks on confirming the diagnosis, and then briefly touching upon follow-up and treatment. Okay, so I will move to the next slide now.
Marc, maybe it
like
would
this?
be, yeah, it would be good only if you click on the full screen modus of the PowerPoint presentation.
Got it. I think I did that right now.
Ah, yeah. Okay.
Okay, excellent. Okay, so the learning objectives are to know all the clinical features of X-linked adrenoleukodystrophy, know how to diagnose it, and know about treatment options. And well, 30 minutes is plenty to cover that. So to start at the basis, X-linked adrenoleukodystrophy is one of the paroxysomal metabolic diseases. And it is one of the single enzyme deficiencies, and it is caused by mutations in a gene called ABCD1. And ABCD1 is an X-linked gene that codes for ALD protein. And as the cartoon shows, ALD protein is a transporter located in the peroxisomal membrane. And deficiency of this ALD protein causes defective transport of very long chain fatty acids, CoA esters, into the peroxisome. And the inside of the peroxisome is where the beta oxidation machinery, where those very long chain fatty acids with 22 or more carbon atoms are degraded. And the deficiency of this transport molecule causes a severe deficiency of this very long chain fatty acid beta oxidation, and that causes the accumulation of these very long chain fatty acids in basically all tissues of the body. And that is the biochemical hallmark of X-linked adrenoleukodystrophy. It's within the rare metabolic diseases, it's not that rare. It is estimated that there, in Europe alone, there should be about 10,000 patients. So that is relatively, that's quite a lot for these kind of conditions.
Marc, Marc, sorry, we don't see the current slide somehow. It is blocked on the speaker slide.
Okay.
That's why so I thought it was only my view, but apparently other people are also not.
Okay, that is problematic. I'm going to try to fix that then.
You may also try to just stop sharing your screen and again restart it. Maybe this, now something happened and we saw the cartoon, but
okay,
it was very short.
I will try again. Can you see it now?
Yeah, now I see the biochemistry and genetics, the first cartoon.
Right.
But anyhow, we see also the next slide, biochemistry and genetics with the graphs. So
Got it. I will try.
This should be smaller, actually.
Yes. I will. How about now?
Yeah, now it's great. Thank you.
Oh, okay, good. Okay, so then we can move to the next slide. So X-linked adrenoleukodystrophy is characterized biochemically by a deficiency in the degradation of these very long-chain fatty acids. And as a consequence, these very long-chain fatty acids, especially C26.0, accumulate. And that is also very useful for diagnostics, because the rightmost graph shows male patients, the little blue squares, and you can see that compared to controls, they all have increased C26 in plasma. So that is a good way to diagnose it. And we'll talk about red triangles, the women, later. So before we go to the clinical features, I would like to ask one question, which will hopefully be answered in the rest of the presentation. So the question is, adrenal failure in ALD, which of the following statements are correct? There can be several answers.
Okay, so now I have started the poll and you can vote. "15 seconds left. Okay, so now we can close it and I can show you the results.
Okay. So most people were correct. And I will now describe the clinical features. And then I hope you agree with me that answer D and only D was correct. Can we move to the next slide?
Try with the
yeah,
flush.
it's working now. Exactly. Okay, so the adrenals are one of the tissues affected in X-linked adrenoleukodystrophy. And it virtually only occurs in male patients. In female patients, it is exceedingly rare, estimated in less than 1%. And in male patients, it is often the first manifestation of the disease, but not always. Patients can also present with neurological manifestations. And the adrenal insufficiency, usually, as the survival curve that is included shows, manifest before the age of 18, about 70 to 80%, but it can also manifest later in adulthood. And what is typical is the like also in long-standing Addison's disease, is the hyperpigmentation. These are the photograph of the knees of a patient we saw last year. And he was considered to have a healthy skin color, but in fact, it was the hyperpigmentation due to the ACTH overproduction. And what is also different from, for instance, Addison's disease, is that in adrenoleukodystrophy, strangely enough, the glucocorticoid producing layer of the adrenal, the zona glomerulosa, is severely affected and usually completely deficient. And the deeper layer, the zona fasciculata, which produces the mineralocorticoids, is usually preserved or partially preserved. So many ALD patients actually only need hydrocortisone supplementation and not fludrocortisone. And in Addison patients, it's virtually always both. So that is a peculiarity of this, of the adrenal insufficiency of ALD. So on to the next symptoms, also introduced by a question. And this concerns the cerebral ALD, and which of the following statements are correct?
Okay, now I will start the second question. Now you can vote. Okay, 15 seconds left. Okay, so here are the results. Just here.
Ah, well, yeah, again, well, B and D were, at least according to me, correct. I see those are, yeah, many people correctly selected those options. So again, I will elaborate on cerebral ALD and hope you agree that B and D are the correct answers. I will try to move forward. Yes. Okay, so cerebral ALD is the leukodystrophy symptom complex in X-linked adrenoleukodystrophy. If it occurs, it is rapidly progressive. Symptoms progress over months to a few years. And the peak onset is between 3 and 10 years of age, so generally in school-going children, but not exclusively. About 35 to 40% is estimated of patients develop it in childhood, but the lifetime prevalence of cerebral ALD is about 60%. So there is also a possibility to develop the leukodystrophy in adulthood. And a few weeks ago, we actually found the onset of cerebral ALD in a 56-year-old man. So although there is a peak in childhood, probably, later in life, it can still develop. Also, like the adrenal insufficiency, the leukodystrophy virtually only occurs in male patients. I mean, there have been a few case reports of women, but it is exceedingly rare. So what are the symptoms? Well, not that different from any other leukodystrophy. Small white matter lesions are, of course, clinically silent. And then when the lesions progress, there is usually the first symptoms are difficult to recognize because they are not specific. They are mostly neuropsychological and psychiatric. So in children, it's usually a learning difficulty, and in adults, dysfunctioning at the workplace, or sometimes overt psychiatric disturbances. But usually the cause is only identified in retrospect, usually only when focal neurological deficits like a hemiparesis or epileptic seizures or severe other neurological deficits occur, that patients are referred to the hospital and the diagnosis is made. And untreated cerebral ALD is usually progressive, causing, like in these old pictures from the 1970s, a boy who is severely with a spastic tetraparesis and basically in a vegetative state. And on autopsy, you usually then see complete destruction and gliosis of the cerebral white matter. So that is the end stage. And although that is often the clinical course. It is estimated that if untreated or not picked up, about 15 to 20% of cerebral ALD lesions can stabilize spontaneously for unknown reasons. So what does it look like on MRI scans? Well, the MRI images are virtually pathognomonic for X-linked adrenoleukodystrophy. About 80% of the cases of cerebral ALD start with small lesions in the splenium of the corpus callosum and then extend into the adjacent white matter and then progress. And what is also, this is actually the only leukodystrophy I know which shows gadolinium enhancement. And yeah, that's difficult to see also on larger images, but the enhancement is not is just beyond the leading edge. On this T1 MRI with gadolinium, you can see that the edge of the lesion is actually here, and just inside is the gadolinium enhancement. And actually, active gadolinium enhancement is a good progressor of an active cerebral ALD lesion that will still progressively enlarge. About 20% of the cases of cerebral ALD start in the genu of the corpus callosum, so and then extend into the white matter. And this is about 20% of cases, and the clinical course is identical to the ones with the more typical occipital presentation. As you saw in the last slides, enhancement is very easy to recognize. And we know this is a pediatric case, but we know that enhancement can also be very, very subtle, especially in adult presentations, which are generally less progressive. And then you can see at the red arrow that you can see that enhancement can be incredibly subtle. And sometimes you have to wait for a long time, 5 to 10 minutes after the contrast administration for the image acquisition to actually see any enhancement. So that's that is a caveat. So the most frequent presentations are the two just described, and in very rare cases it can also begin in the posterior fossa, for instance in the cerebellum, but that is very rare. Well, something that is not often emphasized, but lesions can arrest spontaneously, and that is probably less rare than what we used to think. In large cohort studies, if you scan adults, you can say that about 15% will have a small lesion in the corpus callosum, or a not so small lesion like this patient who was from the outside virtually asymptomatic. And you can see after contrast administration that there is no enhancement. And on follow-up scans, this remains completely stable. So we call that arrested cerebral ALD. And the tricky thing is that that is basically so that it's very unpredictable. Once it arrests, it can stay arrested for years, but we've even seen 10 or 15 years later that the lesion can reactivate and progress again. So it's very unpredictable, but still very, but prognostically, it makes a big difference if it enhances or not. So there is a score that was developed by Luss. Oh, I'm sorry, I messed up the reference. It's actually from Luss from 1994, American Journal of Neuroradiology. Luss and co-workers developed a scoring system that is very easy to use to quantify the lesion load in X-linked adrenoleukodystrophy. And that's important for selecting patients that are still eligible for treatment, as we will discuss later. So those were the first two symptom complexes of ALD. And now I'd like to move forward to the spinal cord disease of X-linked adrenoleukodystrophy. And again, I would like to ask you to indicate which statements you think are correct.
So 15 seconds more to vote. Okay, so here are the results.
Okay, excellent. Well, both A, B, and C were correct as far as I'm concerned. So many people agree with that. Oh, sorry. There we go. Okay. So yes, this is actually maybe the core phenotype of adrenoleukodystrophy in adulthood that virtually all men and most women develop, spinal cord disease. And it is a spinal cord disease characterized by degeneration of primarily the dorsal columns, causing sensory ataxia, and the pyramidal tracts, causing spasticity. So these symptoms combined cause a severe gait disorder. And of course also with sphincter dysfunction, so incontinence for urine and feces. What is also typical that in male patients with ALD there is balding, basically normal male type balding as in this picture, but the only difference is the man on this picture is only 22 years old, so there is really severe premature balding. So if you see somebody on the clinic with a severe myelopathy characterized by the symptoms I just mentioned with balding, then you can have a very high suspicion for adrenoleukodystrophy. And in this case, in this age of exome sequencing, you can maybe opt for specific diagnostics. So what is also typical of this myelopathy is that it actually hardly ever occurs in childhood or in the teenage years, as this survival curve shows from one cohort study. The symptoms start in the 20s and 30s, but then by the time patients reach the age of 50 or 60, virtually all male patients are affected. And there is an enormous variation in the age of onset, and therefore also in the rate of progression that we can not predict at this time. So when we see a 10-year-old patient, we cannot predict whether he will be ambulatory at 40 or wheelchair bound at 25. And also looking at family members has no prognostic information. So that is one of the issues that is not yet understood. So how progressive is this myelopathy? Well, not very. Generally, it progresses over many, many years. And in a cohort study that did clinimetrical follow-up parameters, it takes about 2 years of follow-up before you can reliably measure progression on, for instance, the 6-minute walk test. So that means it's not really rapidly progressive, and it means if you want to do clinical studies on disease-modifying therapies that you're going to need a long follow-up. So if we put it together, you could say that X-linked adrenoleukodystrophy is really kind of a prototypical metabolic disease with patients that are basically all born normal, but then generally develop symptoms over life. And as this graph illustrates, that is often the first symptom is adrenal insufficiency that occurs, let's say, in a large proportion before the age of 10 years, and that is eventually virtually always the spinal cord disease, but that takes much longer to develop, and it can sometimes develop really late in life. And then there's superimposed the cerebral disease that affects about eventually more than 60% of patients, but it's very unpredictable. There seems to be a peak in childhood, but it can also occur later in life. So if you put that together, this is also a nice illustration. You have basically an asymptomatic newborn. This graph only goes for male patients. We will discuss female patients separately, but then eventually somewhere adrenal insufficiency develops. It can be at a very early age. Then the myelopathy will also develop, but usually in adulthood. And then superimposed, sometimes cerebral ALD. So 40% before the age of 18, but can also be in adulthood. And we think since there's absolutely, in any family, all presentations occur, so there must be other factors than just the ABCD1 mutation that determine clinical expression. We think there must be other modifiers, both genetic and environmental, that determine whether you develop those symptoms or not. So in women, like we discussed, adrenal insufficiency and cerebral ALD, for practical purposes, we can say do not occur, but they do get the myelopathy. But the age of onset is much later. That it is pretty rare, from our cohort study, it's pretty rare to occur before the age of 40. But you see that from middle age, most women are affected, but that they are affected, that they have a myelopathy clinically, does not mean that they are severely handicapped. And for instance, progression is much, much slower and occurs over decades rather than years like in the men. So to illustrate that rate of progression, we don't have really good prospective data at this point, for instance, on the 6-minute walk test over time in women, but we do have a cohort study with about 8 years of follow-up. And there you can see that on a commonly used outcome score, ranging from 0 to 10, the EDSS, there's after 8 years a barely measurable difference. So it's really, really slow in women. So how to diagnose X-linked adrenoleukodystrophy? Well, in men, really easy. If you have a clinical suspicion, you can just do plasma very long chain fatty acids. So the C26 and the C26/C22 ratio, and basically all affected men should have abnormal very long chain fatty acids. And of course, then the diagnosis can be confirmed by ABCD1 mutation analysis. So the only thing that should be emphasized, that women with ALD, like we just discussed, are definitely patients. But if you only do a plasma C26, you can see that the women, the red triangles, there's a little bit overlap with the control levels. And in women, about 15% have normal very long chain fatty acids, so the diagnosis can be missed. So if there is a strong index of suspicion, ABCD1 mutation analysis should be done. However, in rare cases, that can pose a problem. Because, for instance, if a woman with a myelopathy has normal very long chain fatty acids, X-linked adrenoleukodystrophy has not been excluded. Then usually doing ABCD1 mutation analysis will provide clarity. For instance, if there is a clear known pathogenic mutation, the diagnosis is confirmed. But say, for instance, if a variant of unknown significance is found, and the plasma very long chain fatty acids are normal, like they are in 15%, the diagnosis is not yet excluded. So in those cases, recently it was published that C26 lyso-PC, another marker for very long chain fatty acids accumulation that can be done either in plasma or in dried blood spots, has a better diagnostic discrimination and is abnormal in women with ALD. So that is a biochemical parameter. And for instance, so that is a recent development that can help. And of course, if there are male relatives that carry the same VUS/OR mutation in ABCD1, they can be tested and provide clarity. And I just added that because it's very nice work. If there is absolutely no other way to find out, you can do a skin biopsy. And Schachmann et al. Described a very elegant way to get fibroblast clones with the active X chromosome that carry the variant so that functional assays can be done. So these days, it is possible to confirm the diagnosis in women also. Well, something that I would just like to touch upon briefly is that newborn screening has been implemented in parts of the United States, and an implementation study will restart soon in the Netherlands. And I'm just mentioning it, and if you want to, you can have a look at www.scanstudy.nl, because this study, because in contrast to the United States, in the Netherlands, we will only screen boys, because boys are the only ones with life-threatening manifestations of the disease that could warrant treatment. So I'm not going to go into detail, but for those interested in newborn screening and newborn screening for ALD, please visit this site. And the newborn screening, of course, will make follow-up from an early age possible to intervene if complications occur. So once you have a patient with the diagnosis X-linked adrenoleukodystrophy, what do you do? Well, usually what we here have a clinic, a kind of a one-stop shop where the patient is seen by an endocrinologist to treat the adrenal insufficiency, or if not present, to screen for the adrenal insufficiency, and also by a neurologist to evaluate for neurological symptoms and do MRI follow-up. And once I will go into more detail in a little bit. If we find an early leukodystrophy, we will consider bone marrow transplant. And because we discussed that the peak incidence of the leukodystrophy of ALD is roughly between 3 and 12, we scan more frequently than we do in adulthood. And this is the algorithm for men, and for women, because they do not develop the adrenal failure or the leukodystrophy, we have no structured follow-up. We only follow them up when they have specific questions. So, like we discussed, basically the prognosis of the leukodystrophy of ALD is pretty poor, because often once it starts, it is relentlessly progressive and causes a vegetative state and death by complications within 2 to 3 years after onset of symptoms. Well, from the 1990s, it has been known that allogenic bone marrow transplants with donor bone marrow can actually stabilize the disease. Problem is that it takes roughly 6 to 12 months after the transplantation for the leukodystrophy to stabilize. So only those patients who are not that symptomatic, or preferably asymptomatic at the time of diagnosis, are eligible, because we know that if the LUS score is above 9, which is a pretty severe leukodystrophy, then the prognosis for, at least for ADL dependence after the procedure, is very poor. And more recently, Pierpont et al. Published in 2017 that actually, even if the LUS score is relatively low, 4.5, that children who are transplanted with a LUS score of 4.5, between 4.5 and 9, in adulthood have a poor cognitive outcome and are often not able to have, for instance, a job and to function independently in society. So the prognosis is really not that good if transplantation is performed in already progressed cerebral ALD. So that is one of the rationales for follow-up and transplantation in pre-symptomatic stage. So people often ask, why not transplant all boys with ALD as soon as the diagnosis is confirmed? Because then you could prevent problems from ever occurring, and you would not need to follow them up every 6 or 12 months. Well, unfortunately, we have it seems very likely that the bone marrow transplant only affects the cerebral ALD component, and not the myelopathy of adulthood, and also not the adrenal insufficiency. There's one retrospective study that shows that boys who were transplanted at an early age still often develop a myelopathy in adulthood. And since bone marrow transplant, even in 2020, is a procedure that is not entirely without risk, severe morbidity and even mortality, and because not all male patients will develop cerebral ALD at this time, preventative treatment with bone marrow transplant is still not an option. Well, there has been, the last years, there have been changes. The allogenic bone marrow transplant is effective, but the problem is that sometimes it can be difficult to find a well-matched donor, especially, for instance, people in Europe who have a unique ethnicity. So that can cause delays in treatment, and also still graft versus host disease is a serious problem. So Oboer et al. They showed in a proof of concept paper in Science that it was possible to use autologous bone marrow transplant with a lentiviral gene therapy, and more recently a new product, LentiD, was shown to be safe and probably effective. So it is possible that this procedure will in the future become an alternative for the classic allogenic bone marrow transplant, although there are still some concerns about the long-term efficacy. So basically, for ALD, so the cerebral ALD, we have a disease-modifying treatment in early stages, but for the myelopathy, unfortunately, at this time there is no disease-modifying therapy. We only have supportive care with spasmolytics, etc. And of course, the adrenal dysfunction is also something that we cannot repair, but only provide a suppletion of hydrocortisone and, if necessary, fludrocortisone. So the progression over time is something that at this time we cannot affect. What always helps patients is that you can explain to them that progression is slow, and that it actually never affects the arms. Generally, it is always limited to the legs. Yeah, and at this time, it's hopeful that there are many people interested in developing treatments for ALD, and there's actually one ongoing trial to evaluate a potential disease-modifying treatment to stabilize the myelopathy, and results are expected somewhere around 2020. So I hope that over the past 35 minutes, I've convinced you that adrenoleukodystrophy is not so rare, and that it is partially treatable, so that it is important to recognize. And I also hope that I convinced you that women are actually patients and not carriers, because that is still often assumed. But I think it is pretty clear that they are absolutely effective. And as suggested reading, there's the paper by Kemp et al. From Nature Reviews Endocrinology from 2016 that basically pretty well summarizes the clinical features and background for ALD that I can heartily recommend. So thank you very much for your attention.
Thank you too, Marc. And now we are welcoming questions in the Q&A section. Just please write your questions and Marc will address them in live here in the webinar. Okay, there is.
I see. Should I read the question or?
Yeah, you can. Do you see it, Marc?
I see it in the chat, but
the chat. Yes.
Should I read it, or can everybody see it?
Yes, it would be great if you can read it. Yes.
Okay, I will just summarize it. The question is if an 8-year-old boy with cerebral ALD and a loss score of 13 with a neurological function score of 3 would still be eligible for bone marrow transplant. And the second part of the question, what kind of alternative treatments there would be? Yeah. Yeah, that's a very good question. And yeah, the problem is with these cases of cerebral ALD that are already very advanced is what what is already mentioned, that usually when you start the treatment with the chemotherapy, there's rapid worsening, and that can be pretty severe and actually be very devastating. And there's the additional problem that it takes a long time for the bone marrow transplant to actually stop the leukodystrophy. So basically, when we see somebody with overt neurological dysfunction and a LUS score of 13, we would not consider them eligible for bone marrow transplant. And not because just because we think that the outcome is really horrible. And of course, if the bone marrow transplant, if the procedure, if the patient survives the procedure, they end up in really a bedridden condition with very low quality of life. So we think that such an invasive and unpleasant procedure with an expected outcome that is so poor is hardly justifiable. And the difficult thing is that at this time there is really no proven alternative treatment. So that is really sad. But I think the only thing you have to offer your patient is compassionate care and symptomatic treatment. But we in cooperation with our transplant center in Utrecht, who generally really advise against performing a bone marrow transplant, because it will only cause devastating misery. And it's not that the bone marrow transplant won't work. If the patient survives, the leukodystrophy will stop, but it will. But the end result will be a patient with no quality of life. But of course, that is a very difficult because at this point, with LUS score 13 and NFS 3, you still have a patient who's functioning at a reasonable level. So it's very difficult to do nothing. But I think there is really not much you can do at this point. And as for alternative treatments, well, there's one trial by Minorix where they try to where they enroll patients with cerebral ALD to see if their compound could stabilize it, but that is really experimental. There's no evidence, but you could consider contacting Minorix if there is a possibility for compassionate use or participating in their trial. Okay, so shall I move to the next question?
Yes,
Okay.
Thank you.
It's a question: in the adult phenotype, what prevails, the atactic or spastic? In my experience, eventually the spastic. That is what is most visible on the outside, the pronounced spasticity and pyramidal tract signs. Absolutely. But very early on, you can already see the sensory ataxia with the abnormal vibration sense. But when the disease is progressive, the spastic components becomes the most prominent.
Mm-hmm. Thank you. And now those are so now again I will I propose to move on with the questions that were asked in the question and answer section.
Yeah, shall I just ask, there's one follow-up question based on the patient with the high LUS score, if there's any experience with dimethyl fumarate. Not that I know of, but please feel free to email me afterwards, because that is also a question that could be put to one of the transplant centers. They often have experience, but feel free to email and I can put you in contact with a transplant center that might have some insights on that.
Okay, thank you, Francesco. And now here the questions in the Q&A section. When is too late for a bone marrow transplant?
Right. Yeah, that is generally we consider the MRI to be a very important parameter, and generally say when the LUS score is 9 or higher, then the outcome will not be good functionally. So then you should really consider whether it's still a meaningful procedure. So a LUS score of 9, of course, combined with the clinical condition of the patient.
Okay, thank you. Then the next question, are other organs outside of the central nervous system and adrenal gland susceptible to damage from accumulation of VLCFAs?
Yeah, interesting.
An inflammatory response, yeah.
Right. Yeah, interesting point. As far as we know, only the testis, there is some evidence that there is some testicular dysfunction, although that seems to be clinically not very relevant because most male patients have normal fertility and actually have children. So there are some older papers that suggest that many patients have low testosterone levels, but clinically that does not seem to be a problem. And as for other organs like lung, liver, seem to be absolutely fine.
Mm-hmm. Thank you. And the last question, do you offer Lorenzo's oil to your patients?
Yeah. No, not anymore. Yeah, I can give a very long answer or a very short answer. No, basically, no, because there is really no evidence of efficacy. On the contrary, all the studies that have been done show that there is progression of cerebral ALD if you use it. There is progression of the myelopathy if you use it. So there is really no clear benefit. And it is a pretty unpleasant treatment which does have side effects. So if you balance it, no proven efficacy with real side effects, then we decided no longer to offer it. But I know that there are some countries in which it is still prescribed. Yeah.
Okay, thank you. So it seems that we don't have any other questions, and if it is so, then we can close this webinar. Thank you everybody for attending. Thank you, Marc, and take care everybody, stay safe, and until the next webinar in April 14th.
Thank you. Have a good day, everybody.
You too, bye-bye.